Dear students, welcome to my new channel. In today's lecture, we'll learn about distribution of drug under the codes of biopharmaceutics and pharmacokinetics. So let's start. So what is distribution? It is the movement of drug between one compartment and the other. Distribution is the reversible transfer of a drug from one location to another within the body. So it is a reversible transfer. But if we see the elimination is irreversible, but distribution is reversible. The distribution of the drug between tissues is dependent on vascular permeability, regional blood flow, cardiac output, perfusion rate of the tissue, and the ability of the drug to bind tissue and plasma protein and its lipid solubility. We'll discuss all of this in the upcoming slides. So distribution is the passage of the drug from the circulation to the tissue and the site of action. The extent of distribution of drug depends on its lipid solubility, ionization at physiological pH, extent of binding to plasma and tissue protein, and differences in regional blood flow. Diseases like congestive heart failure, uremia, cirrhosis. Movement of drug until equilibrium between the unbound drug in plasma and tissue fluid. The drug is easily distributed in highly perfused organ like liver, heart, and kidney. It is distributed in small quantities through less perfused tissues like muscle, fat, peripheral organs. So as we have learned from the gastrointestinal lumen, first of all, the drug is absorbed into blood. So when the drug is coming into blood, after coming into blood, the drug will distribute it through different organs. Okay, like it would distribute it into the brain. From the blood, it would distribution into the kidney. Okay, from the blood, it will come into the heart. Okay, so this is overall the distribution of drug within different organs. So from GI tract, drug is firstly absorbed. This is called absorption. We have separate video upon this. And after the absorption, drug will ultimately go for distribution in different tissue. So whenever drug is administered, it comes into the blood, and after the availability of the blood, then it will again distribute it into different organs like vascular compartment, okay, extracellular space, body fat, bones, placenta, brain. In each of the organ, the drug would be distributed. So there are a number of factors of distribution like lipid solubility of drug. The more lipid soluble, the more would be the distribution because our biological membrane is lipophilic in nature. Then cardiac output and local blood flow is does impact on this distribution. Then presence of tissue specific transporter, binding of drug to plasma protein and tissues, capillary permeability. These are the all factors. We'll discuss this in upcoming slides. So to understand the distribution, firstly we need to learn the apparent volume of distribution. Okay, because this is one of the pharmacokinetic parameters which determines the distribution of drug in the body. So we need to learn about that. So total space which should be available in the body to certain amount of the drug. So volume of distribution is the total amount of drug divided by concentration. So if you know some VD would be is equal to amount of the drug. We denote this is X. Okay, amount of the drug divided by CP, blood concentration. This is very simple equation. We'll do some problems and solves solution regarding this equation. Drug does not cross capillary wall. High molecular weight drug like heparin, insulin, okay, because their particle size is much more higher. So lesser lipid soluble drug cannot cross the capillary wall. So for the distribution, the drug should be low molecular weight and with high volume of distribution or high lipid solubility. Okay, drugs that bind to the protein, highly bound to the plasma protein drug will have low volume of distribution. Why? Because the drug which are highly bound to the plasma protein will retain on the blood. They will not come into brain, they will not come into liver, they will not come into uh, uh, lungs or any other organ. Okay, so laser bound to the plasma protein, high volume of distribution. Volume of distribution of some drugs is much more than actual body volume. Widely distributed in the body, for example, digoxin, imipramine, phenobarbital, analogs of morphine. So these are difficult to remove by dialysis if toxicity occurs. So the drug which are having the higher volume of distribution will distribute it throughout the different organs in our body, and ultimately its concentration in the blood will be decreased. So if we see, you can find out that the drug which are having less than 5 liter uh, volume of distribution, it will retain in the vascular compartment. Okay, because it's not distributed. For example, heparin, insulin, warfarin, these are water soluble drugs, and this drug would remain in the blood. Why? Because blood itself is water. Okay, blood basically composed of water and blood cells. Water constitute 55% of the blood. So blood is somehow hydrophilic. Okay, so the drug which are having the lower volume of distribution will ultimately remain in the blood. So the drug which are having very high volume of distribution, what does it mean? It means it is distributed through total body water, okay, within the body tissues, okay, various tissues. For example, like ethanol, phenytoin, methyl dopa, digoxin, imipramine, morphine. Okay, these are the drugs which are distributed throughout the body. So for better understanding of the distribution and other pharmacokinetic parameter, we have arranged these tables. So if we see that when volume of distribution is higher, it is it will have ultimately more T half or half life. So why high volume distribution uh, tend to increase the half life? Usually, half life means the time in which the drug concentration is in blood reduced to 50%. So high volume of distribution means what? It will be distributed throughout the different tissue of the organ. So they will just remain in the body. Okay, so their half-life would increase. Then duration of action will ultimately increase because they are distributed. Their activity, that is biological activity, would decrease, increase. Okay, their tissue level will increase. Tissue level means concentration of the drug in tissue. Then their toxicity would be increased if volume of distribution is high. Why? Because the drug is distributed throughout different organs. Okay, they are remaining in different organ. They are not in the blood. They are in the organ. So whenever they are in the organ and passing most of their time in the organ, then may cause toxicity. Then increasing the volume of distribution will ultimately increase the reabsorption. So where does reabsorption happen? So keep in mind that in our body, usually two types of absorption happen. First absorption happens in the GI tract that we have already read in our previous lecture. So first absorption is in GI tract, okay, and our reabsorption, that is the second absorption, takes place in the kidney. Okay, so when volume of distribution is increasing, the lipophilicity is increasing. So the more lipophilicity, the more would be the absorption and reabsorption. Okay, ultimately, what would happen? The drug would be reabsorbed throughout the kidney, and no drug will get eliminated. We'll see this here. Okay, increasing the volume of distribution will ultimately decrease excretion, decrease the clearance, decrease the elimination rate constant. Okay, this property has decreased. Why decreased? Because reabsorption has increased in kidney. Okay, why reabsorption has increased? Because of the lipophilicity of the drug. The drug accumulation would increase. You can easily understand that if the drug travels most of our organ, then their accumulation may increase. Then increasing the volume of distribution, the drug which are having the high volume of distribution is suitable for sustained release dosage form. Why sustained release dosage form? Because what is the definition of sustained release dosage form? Sustained release dosage form are those dosage form that provide the medicament at a predetermined rate over an extended period of time. Okay, so these are suitable for extended period of time, and drug having the higher VD is already passing and already traveling in our different body organ for extended period of time. So these are suitable for SRDF. So the drug which are having the high VD requires high loading dose. So why high loading dose? Our drug activity is measured upon the plasma concentration. But the drug which are having the high volume of distribution, what will happen to them? They will not be in plasma, they will be in different organ. Okay, but we do measure our activity by drug plasma concentration. That is, we have already read the AUC curve, the drug plasma concentration time profile curve. This is the CP. But drug which are having the high VD will not be in blood. Okay, their CP will decreased. Okay, we have already shown here the drug which are having the high VD, the CP has decreased. So whenever CP has decreased, their dose would be decreased because the drug is in different organ, not in the blood. Okay, so high loading dose or dose is triggered. So this is important for volume of distribution. However, some of the properties are inversely related to the volume of distribution. For example, solubility. It is inversely proportional to VD. Then excretion, elimination rate constant, clearance. These are inversely proportional to volume of distribution. Then we have already read that increasing the volume of distribution will decrease the plasma protein binding. Why? Because whenever the drug has high volume of distribution, it will not bound to the plasma. Okay, it will not bound to the plasma protein. Rather, they will come into the different organs. Okay, so plasma protein binding will decrease. And the last property is increasing the volume of distribution will decrease the dialysability. So what is dialysability? So it means the dialysis. Okay, kidney dialysis that we perform for the kidney failure patient. So to dialyze a blood, drug should be within the uh, blood. Okay, it should not be distributed. So dialysability decreased for increased volume of distribution. So these are the overall scenario. If you can remember this relation, you can easily understand the absorption pattern of the drug, the distribution pattern of the drug, the elimination, excretion pattern of the drug, the metabolism pattern of the drug. If you just go through this table. Okay, so this table is very important for understanding biopharmaceutics and pharmacokinetics. So next slide. So now distribution into the water compartments of body. Plasma compartment, drug having high molecular weight or extensively plasma protein bound drug, okay, will be in plasma. In extracellular fluid, low molecular weight but hydrophilic drug will be in extracellular fluid. And in total body water, the drug which are lipophilic and low molecular weight will be distributed throughout the body. So let's see, one of the critical factor for drug distribution is drug protein binding. You know, we have already discussed whenever drug is coming into blood, this is blood, this is the GI tract, from GI tract drug is coming into blood, drug would ultimately bound to the plasma protein. Okay, imagine you need to go to Chittagong from Dhaka. Then how would you go? You would ultimately go by a transporter or a transport. Okay, in bus or aeroplane or any other vehicle. Okay, you will not go there by just walking because it's a long distance. So the same reason is for the drug. Drug need to travel throughout the body and it needs a carrier, it needs a vehicle. Okay, the vehicle is protein, several plasma protein like human serum albumin, alpha acid glycoprotein, lipoprotein, globulin, hemoglobin. These are the blood protein which are available and we have already read this in our intermediate sections. So plasma protein binding has a greater influence in drug distribution and drug metabolism. So in serum albumin, all types of drug bounds. Okay, we can remember this by L. L means all. With alpha acid glycoprotein, as it is acidic, it will attract the basic drug because acid will react with basic. Okay, we know acid and base react with one another to form salt. Then uh, lipoprotein, we know lipoprotein are these will attract basic or lipophilic drugs because lipid, and here is the lipid. Okay, so they will attract the lipophilic drug, they will bind to these drugs. Then globulin. Okay, uh, if we consider an egg, its yellow portion is the globulin and the outer portion is albumin. Okay, so globulin, sometimes doctor prevent some heart patient or any other patient, diabetes patient, to take globulin. Okay, doctor sometimes restrict this globulin to be intake. So why globulin? Because globulin, this uh, bind steroid related drugs like corticosteroid, okay, vitamin A, D, E, K, these are fat soluble. Okay, so fats, steroids are get bound to globulin. And lastly, hemoglobin, like phenytoin, phenothiazine. So these are the overall protein binding. First of all, we'll see how actually this protein bound to the drug. Whenever discovered, albumin has different binding sites, site 1, site 2, site 3, and site 4. And when discovered, scientist has firstly uh, analyzed these drugs for binding. Okay, but don't get confused that yes, this receptor, this site 1 will always bind warfarin, this site 2 will always bind diazepam. This is not like that. Many other drug will bind to this site. Okay, many other drug will bind to this site, diazepam site. Okay, so for example, albumin has different binding site. Drug will bind to there. Okay, imagine this is a drug. Drug will bind to this. Okay, this is the overall protein, blood protein, and this is the different binding sites. Most of the drugs will bind to site 1 of albumin. Few drugs will bind to the site 2, and some of the drugs will bind to site 3 and 4. So let's check different properties of albumin, as it is the mostly found and mostly available blood protein. So its molecular weight is 65,000. It's the most abundant. It constitutes 59% of total plasma. So total amount is 3.5 to 5 gram percentage. Large binding capacity. Okay, almost all of the drug will bind to uh, albumin. So weakly acidic drugs, weakly basic drugs, neutral drugs, all drug will bind with albumin. Then alpha acid glycoprotein, as we have already said, that it is acid glycoprotein. So it will bound with basic drugs like propranolol, lidocaine, quinidine. Then lipoprotein, as you know, like dissolves like. So lipoprotein will attract the lipophilic drug. Okay, so its concentration is much less. Lipophilic drug will bound to this. Okay, uh, basic or lipophilic drug has most affinity. Then globulin, we know different types of globulins are present: alpha 1, alpha 2, beta 1, beta 2, gamma globulin. Okay, we know this is one of the popular one for antigen antibody binding. So alpha 1 globulin, it is also called transcortin, and it is corticosteroid binding globulin because it binds to different steroidal drug like prednisolone, cortisone. Okay, we know steroidal drug are very much important as hormonal replacement therapy or several asthma related drugs. Then alpha 2 globulin, it is also called ceruloplasmin. Vitamin A, D, E, K or cupric binds to this. Then beta 1 globulin, it is also called transferrin. Okay, we know ferrin. Ferrin means ferric, that is ferrous ion binds to this. Then beta 2 globulin, these are carotenoid binds. Okay, these bind carotenoids with it. So we have already read this that only free drug will show therapeutic action. So this is the blood, these are the blood protein. Okay, this is the protein. These drugs are bound to plasma protein, but these drugs are free. So only the free drug will go to cell and give therapeutic action. So free drug is also called unbound drug. So always keep in mind that bound drug will never ever give any activity. Only the unbound drug or free drug will give therapeutic activity. So same thing has been shown here. So let's discuss different factors affecting protein drug binding. In our previous lecture, we have already read different biopharmaceutical factors which affect our gastrointestinal absorption of drug. Now we'll discuss different factors which will affect protein drug binding or ultimately will affect the drug distribution. Okay, because this protein drug binding will ultimately impact the overall distribution. So let's discuss. So we can see some of the factors which affect the protein drug binding or drug distribution. It is easily understandable that nearly some of the properties are very much equivalent with the factors affecting the absorption. So let's start with the factors affecting the related to the drug, like physicochemical properties of the drug, concentration of the drug, affinity of the drug for a particular binding component. Then factor related to protein, as drug will bind to the protein. Okay, this is the drug, this will bind to the protein. So some factors would be related to the protein, some factor would be related to the drug. So physicochemical property of protein, concentration of protein, number of the binding site on the protein. As we have already seen that albumin has 4 binding sites. Okay, site 1, 2, 3, 4. Then drug interaction. So our next factor is drug interaction with the protein. Okay, how the drug will interact with the protein. So competition between drug for the binding site may happen. Competition between drugs, normal body constituent may happen. Allosteric changes in protein molecule. We have learned this in pharmacology, like agonist, antagonist. You can already remember. These are related to the protein. Okay, we have learned different G protein coupled receptors or ion channel receptors in our pharmacology course. Okay, so this thing is very much related to this. However, there are some patient-related factors like age, disease states, intersubject variation, etc. So let's discuss the factor related to the drug. So higher the lipophilicity of the drug, greater the protein binding. Anionic drug binds to human serum albumin. We have already learned. Then cationic drug, that is basic drug, will bind to the alpha acid glycoprotein. So why acidic drug are anionic? Because acidic drug contains COO minus. Then why basic drug are cationic? Basic drug usually contain amino, okay, NH2 group, and NH2 is plus, positive charged. So these are positive charged. Then neutral or unionized drug bind to lipoprotein. Then concentration of the drug in the body, increasing the concentration of the drug will ultimately increase the protein binding. Okay, but this should not be too high because our protein is also limited. Then drug protein or tissue affinity. Digoxin has more affinity for cardiac muscle. Lidocaine has more affinity for alpha acid glycoprotein than human serum albumin. However, there are some factors related to the protein, like physicochemical factors. Then concentration of protein. Okay, increasing or decreasing the concentration will alter the protein binding. The number of binding site on protein. Okay, so albumin have large number of binding site. So more of the drug will bind to albumin. Then drug interaction. So in some cases, we can see here that, for example, this bound to this receptor. But whenever a drug will come, it will displace this and bound to this receptor. So this is the case of displacement. For example, albumin. Albumin has 4 binding site. Okay, we have already seen this, that albumin has 4 binding site and warfarin bound to this site 1. So there are some drugs, okay, which sometimes bound to this warfarin binding site and displace what? Displace warfarin. It's like that. Okay, for example, this is warfarin. this naturally warfarin binds to this place, but whenever we are taking some drugs which interact with this receptor, then warfarin gets free. Whenever warfarin is getting free, then its free drug concentration will increase. So increasing the free drug concentration, what will ultimately happen? This will create toxicity. Okay. So this has been shown here. Warfarin is easily displaced by most of the drug. Free warfarin is increased, leads to hemorrhage or death. Warfarin found drug interaction with most of the drug. Then competition between the drug and normal body constituent. Okay. For example, sulfonamides displace the bilirubin from albumin binding site. Then allostatic changes in protein molecule. So what is allostatic site? In the enzyme, along with the receptor in which drug bind, there are some other receptors which is in the other side of the actual receptor. So these are allostatic site. Okay. So these are some secondary sites for drug action or drug affinity. So allostatic inhibitor is a drug molecule and is non-competitive with green molecule for that site. Okay. This is non-competitive, but somehow allostatic inhibitor binds to some drug site and do changes in the site of green molecule. So green molecule replace and become free drug. Okay. So there are some patient-related factors because whenever if we are some pediatric patient, there is low albumin, low drug protein binding. So if drug protein binding is low, then high concentration of free drug, then less dose is preferred. That is why pediatricians or pediatric patients are given low dose. Okay. So in case of elderly patient, two scenario can happen. Sometimes as they are getting aged, their albumin will decreased. Okay. So whenever albumin is decreased, the uh, scenario would be like a neonate. But whenever albumin would increased, okay, their scenario would be different. However, there are some genetic factors and environmental factors. So let's see the clinical implications of protein drug binding. High plasma protein bound drug does not cross membrane, so largely restricted to vascular compartment. We have already read this. Okay, the drug which are mostly bound to the plasma protein will ultimately retain where? In the blood. Okay, temporary storage of drug which is not available for any action. High degree of protein binding generally makes the drug long acting. So why long acting? Because as it is bound to the protein, it will not ultimately get filtered in the where? In the nephron. Okay, because it is protein bound drug. Whenever drug is coming and blood is going, drug is also going with the blood. Drug is not coming into the nephron and going into the bladder or urethra. Okay, so high protein bound drug will ultimately get not excreted. Okay, so whenever drug is not excreted, that means it would be longer lasting. Plasma concentration of the drug refer to bound as well as free drug. One drug can bind to many sites on the albumin molecule. Displacement reaction, we have already seen this. There are some displacement reaction can happen. For example, sulfonamide and vitamin K displace bilirubin. In hypoalbuminemia, that is decreased concentration of albumin in blood, reduced binding leads to high concentration of free drug. However, there are some other diseases like phenytoin and pethidine binding is reduced in uremia. So we'll see another term, that is redistribution. Okay, so in our body, keep in mind that we see different re. For example, absorption, and another term is reabsorption. Absorption is happening in GI tract, reabsorption is happening in kidney. Then distribution is happening in body organs. Okay, so what is redistribution? Re means again. Okay, that is repeated distribution. So sometimes highly lipid soluble drug get initially distributed to organs with high blood flow and later into bulky less vascular tissue. Okay. So plasma concentration falls and the drug is withdrawn from this site. If the site of the action of the drug is one of the highly perfused organ, redistribution may result in termination of the drug action. Greater the lipid solubility, faster is the redistribution. So why redistribution is happening? Drug, for example, drug is distributed from blood in a tissue like brain. Sometimes from the brain, the drug comes into heart because it is highly lipid soluble. Then after some times from the heart it again comes into lung. From the lung it again comes into body fats. Okay, so this is redistribution. Greater the lipid solubility, the more would be the redistribution. Anesthetic action of thiopental sodium injected is terminated in few minutes due to redistribution. To overcome, give continuous infusion. So why this is happening, we need to learn that. So anesthetic drugs will act on brain, but it is problematic when redistribution happens. Why? Because as the drug is redistributed, the thiopentone is redistributed, it is not creating the anesthesia in the brain, rather it is going to different organs. Ultimately our dosage regimen would be hampered. Okay, so to overcome this we give continuous infusion. So let's discuss different physiological barrier to diffusion of drug. As we have already seen, first of all, drug is coming from GI tract to the blood. Okay, very good. Drug has come into the blood. Here it uh, bound to different protein. Very good. After that, it comes to different tissue. You know, it comes to uh, brain. Then it comes to heart. That is the kidney. It comes to kidney. Okay. Then from here it comes to heart. This is the heart. Okay, so important thing is that there are some barriers for the drug to get into a particular organ. We heard some of this barrier like blood brain barrier. The brain has blood brain barrier. Okay, that blood placental barrier, for example, this is a placenta. Okay, so there is a barrier between blood and placenta. So why this barrier? Actually, this barrier helps in protecting our critical organs. If you notice that, you'll find out that these barrier are present in some critical organ in our body because this prevent unusual distribution of blood in that tissue. Okay, because it may create toxicity in that particular organ. Like brain, this is the most important organ. It has some barrier. Then placenta, you know, every one of us have passed some of our times during embryal or fetal period here. This is a crucial thing. Okay, then testis. Here, sperm is produced and one of the most crucial organ for reproduction. Okay, so very critical organs. So there are some barriers. Moreover, along with this, in each and every organ, there are some capillary endothelial barrier or normal cell membrane barrier. So the membrane with special structure features can be permeability restriction to distribution of drug to some tissue. Some of the important barrier are these. So these are the some barriers, placental barrier, BBB, cerebrospinal fluid, CSF barrier, then cell membrane barrier, capillary barrier, testis barrier. Okay. So let's discuss one by one. First of all, simple capillary endothelial barrier. This is found in capillary. We know whenever blood is from, this is aorta. So from blood, several other tissue is distributed. Okay, these are forming capillary. Okay, this is vein. Okay, these are forming the capillary. Okay, so this is the capillary barrier. So capillary supply the blood to the most inner tissue. All drug, ionized or unionized, molecular size less than 600 Dalton, diffused through the capillary endothelium to interstitial fluid. Only drug that bound to blood components can't pass through this barrier because of large size of complex. So let's see here the capillary barrier. we have shown two simple barriers here. One is simple capillary barrier and another is cell membrane barrier. Okay, so we can see here, this is the blood and this is the cell. Okay, between blood and cell, extracellular fluid is present. Okay, from the blood and extracellular fluid, the simple capillary endothelial barrier exists, and between the ECF and intracellular fluid, or that is ICF, simple cell membrane barrier exists. So how drug is coming? Drug is coming through passive diffusion. This is the drug protein bounding. The free drug only can come here, and drug of size less than 550 Dalton can easily pass through these ports. Then lipophilic drug will pass through how? By passive diffusion. Okay. Then polar or ionized drug will pass through different carrier, as we have already seen in our previous lectures. Then simple cell membrane barrier. Once the drug diffuses through the capillary to the ECF, its further entry into cells of most tissue is limited. Simple cell membrane is similar to the lipoidal barrier. Nonpolar and hydrophilic drug will pass through it. Lipophilic drug with 50 to 600 Dalton molecular size and hydrophilic drug with less than 50 Dalton will pass this membrane. So lipophilic drug has better accessibility because drug is lipophilic and cell membrane is lipophilic, and easily by passive diffusion, whatever the size is, they are passing to the cell. But in case of hydrophilic or polar drug, carrier is needed because they are hydrophilic but the cell is lipophilic. Okay, so if their size is less than 50, it is okay, but if the size is more than 50, then obviously uh, carrier is needed. Then the most important barrier in our body is blood-brain barrier. So capillary in the brain is highly specialized and much less permeable to water-soluble drug. Endothelial cells tightly bound with each other by intracellular junction, astrocyte present at the base of endothelial tissue and act as supporting material, and from envelope around the capillary, thus intracellular passages get blocked. BBB is lipoidal barrier, thus drug with high partition coefficient diffuse passively, others and partially ionized molecule passed slowly. Polar natured substance transported to brain actively, thus structurally similar drug can pass easily to BBB. So this is the blood-brain barrier, this is the blood, this is the extracellular fluid, and this is the brain. Okay, so nonpolar lipophilic ionized drug can easily travel by passive diffusion. Okay, but polar drug cannot travel this. Okay, this is the main barrier. So penicillin cannot cross blood-brain barrier. However, there are different approaches to cross blood-brain barrier, like permeation enhancer, pro-drug approach, like dopamine is converted to levodopa, because dopamine is polar and levodopa is non-polar. Then different carrier system like dihydropyridine moiety redox system. Okay, then complex formation. After entering in the brain, uh, dihydropyridine gets metabolized by CNS enzyme in brain and drugs get trapped inside the brain. Okay, so you can see here highly lipophilic, okay, or partially ionized drug are easily welcome to the brain, but polar drug, ionized drug, water soluble drug are not uh, getting through this BBB. Dopamine cannot go. Why? Because as the name suggests, dopamine, amine, okay, it's a polar drug, but levodopa, it is a prodrug of dopamine. It is given as the medicine, and it can easily get to the brain and can treat Parkinson disease. So next one is the blood cerebrospinal fluid barrier. This is as like as our blood-brain barrier. In blood-brain barrier, there is also tight junction, then choroid plexus, then capillary endothelium. So here is the tight junction. Okay, this is the tight junction. This tight junction is also appeared in blood-brain barrier. So you can see highly lipid soluble drug can only pass through this. Okay, so drug cannot pass through this tight junction. Okay, So capillary endothelial cell have open junction or gaps, so drug can flow freely between capillary wall and choroidal cell. Choroid plexus. Major components of CSF barrier is choroid cells which are joined with each other by tight junction, forming the blood CSF barrier. Highly lipid soluble drug can easily cross the blood CSF barrier, but moderately soluble or ionized drug permeate slowly. So mechanism of drug transport is similar to CNS and CSF, but the degree of uptake may vary significantly. Basically, mechanism of transport is same for CNS and CSF. And our next one is blood placental barrier. So it's the barrier between the maternal and fetal blood vessel. Both are separated by fetal trophoblast, basement membrane, and endothelium. Thickness is 25 micron. Okay, at early pregnancy, but later it reduces up to 2 micron. Molecular weight less than 1000 Dalton and moderate to high lipid soluble drug like sulfonamide, barbiturates, steroid, nicotine, some antibiotics cross this barrier by simple diffusion repeatedly. So you can think that whenever mother is taking these drugs, this drug will ultimately go to placenta. Uh, when mother is taking antibiotics or steroid or barbiturates, but some sleeping pills, okay, sulfonamides, these are antibiotics or diuretics, okay. So this drug will ultimately travel to placenta and go to the fetus. So very dangerous for the embryo, okay. Next, essential nutrients for fetal growth transported by carrier mediated process. Immunoglobulin are transported by endocytosis. Drugs dangerous to fetus at 2 stages. It is advisable to avoid drugs during the first trimester because major organogenesis or organ formation happened in this time. Some drugs can produce teratogenic effect, okay, like phenytoin, methotrexate. Later stage pregnancy affect physiological function like respiratory depression, like morphine. Okay. So it is better to restrict all drugs during pregnancy. So it is advisable to women to take any drug during pregnancy. Okay, because any other drug which are having molecular weight less than 1000 will ultimately travel by simple diffusion method. Okay, so it is better to not to take any drug during this period because overall this drug will cross this membrane barrier and ultimately go to the fetus. You can see here the uh, uh, barrier. This is the main barrier, okay, this is the barrier, and here is the maternal blood flow, the maternal artery and vein, and here is the fetal brain and artery, okay. So usually fetal membrane is composed of trophoblast and endothelium. So drug which are less than 1000 Dalton can pass through this, or lipophilic drug can pass through this. Okay. So this is maternal flow and this is the fetal flow. And the last barrier is blood testis barrier. This barrier not located capillary endothelium level, but at Sertoli cell junction. It is the tight junction barrier between neighboring Sertoli cell that act as blood testis barrier. This barrier restrict the passage of drugs to spermatocytes and spermatid because these are the cells from where all the 8 billion people of the world was formed. Okay, so these cells are very much crucial. These cells are not as like other our body cells like myocytes or any other cell in our body. These are specialized cell because these are the cells that can form a new living thing, okay, new living being, so this cell also contains some tail, okay, they can move, okay. So there should be restriction of drugs from entering to this location. That's why this barrier. So this is the ending of our chapter. We have provided two problems and solutions for better understanding. Please solve it yourself. So these are all from our lecture regarding drug distribution under the biopharmaceutics course. If you have any confusion, please inform me in the comment section. Thank you.